Hello everybody. Today we are going to see about the histopathology of enamel caries. First we'll see about the histopathology of smooth surface caries. Smooth surface caries, it can be divided into early caries and advanced caries. So the early caries shows features like loss of interprismatic interrod substance, prominence of rods, roughening of ends of enamel rods, early attack of prism, accentuation of Retzius line, grains ray picture which shows loss of minerals in Retzius lines which causes the organic material to be more prominent, accentuation of pericymata. The advanced caries or deep caries shows a triangular shaped defect with the apex towards the DEG and base near the surface of the tooth, as in this case. The apex of the triangle is near the DEJ and the base is near the surface. The next type is the pit and fissure caries, which shows the enamel lamella found at the base of the pit and fissure. The early lesions are more permeable to stains like methyl green and alizarin red, free of calcium ions. Normal enamel are usually uncolored by these dyes. Triangular shaped defect with the base towards the DEG and apex near the surface of the tooth. So this is just the opposite of what we saw in the smooth surface caries. So the apex of the triangle is near the surface and the base is near the DEJ. So what can start as a small lesion can actually spread out to be a big one. And that's why pit and fissure caries are more dangerous and need immediate intervention. So looking into the histopathologic zones of enamel caries. So if we see from the pulp towards the surface, okay, from inwards towards outwards, we have four zones. Okay, the first zone is translucent zone, which is the first recognizable zone of alteration, which is advancing front of the lesion. Half of the lesions demonstrate this zone, not always present. Seen in longitudinal ground sections, this zone appears structureless and the pore volume is usually 1% compared to 0.1% of sound enamel. The next zone is a dark zone which lies adjacent and superficial to the translucent zone, and it's also called the positive zone. Shows positive birefringence in contrast to the sound enamel. Pore volume is 2 to 4% under polarized light. Presence of small pores, large molecules of quinolone are unable to penetrate. Micropore system gets filled with air and becomes dark and hence called the dark zone. Medium like water may penetrate. The third layer is the body of the lesion, present between the unaffected surface in the dark zone, area of greatest demineralization. So this is the area to be looked for. The pore volume is almost 5% in the periphery and 25% in the center. Quinolone imbibition, body appears transparent. Water imbibition, positive birefringence compared to the sound enamel. Striae of Retzius are prominent. The last zone towards the surface is surface zone. Quantitative studies show partial demineralization of 1 to 10%. The pore volume is less than 5% of the spaces. So this is the picture depicting the different zones, and these are the enamel tufts. This is the surface zone, which is relatively apparently unaffected. This is the body of the lesion, the greatest area of demineralization. Next is the dark zone, appearing dark and because it's filled with air, and last is a translucent. So generally the translucent, we remember it like TDBS. Okay, so that's how we easy to remember. So it is from the pulp towards outwards. So it is translucent zone. That is what it's called. As the lesion proceeds from the surface towards the pulp, translucent zone is said to be present towards the advancing front of the lesion, because as the lesion goes in this direction, towards the pulp is the advancing front of the lesion. So translucent zone is present near the pulp, and surface zone, as the name indicates, is present on the or near the surface. So what are the ultrastructural changes seen in enamel caries? Difficult to prepare ultra-thin enamel sections, scattered destruction of the when it is prepared, we see scattered destruction of individual apatite crystals, broadening of intercrystalline spaces. These are evident in the body of the lesion with pore volume 10 to 25%, which we already saw. As dissolved crystals increase in amount, densely calcified tissue become more porous, and different crystal forms seen at the periphery, that is larger, isodiametric of greater size than that of the sound enamel, formed due to the remineralization of the crystals that have resisted dissolution. Thus, greater diffuse crystal destruction, numerous bacteria invade the enamelation. So this forms the crux. The last line forms the crux of the entire theory behind the caries advancing towards the deeper surfaces. Okay, as the crystals are the crystalline structure of enamel is its hallmark. So as there is a greater and greater diffuse destruction of crystals, enamel crystal structure, numerous bacteria use this opportunity, okay, and become opportunistic and invade the enamel lesion, okay, and make it larger and larger. Thank you.